We are live.
Okay,
Hello everyone. Good evening. A warm welcome to you all for today's Pediatric Knowledge Cafe on certain issues with COVID-19. On behalf of Meyer Organics, we hope and wish you all are safe, and we also thank you all for giving your service hands to combat COVID-19. We are very happy to serve India's children with Kiricare Plus syrup, Colicate drops, Ultra D3 drops, Osteocare, Kiricare Pro with all essential multinutrient to support their health in pandemic. So today we have our esteemed faculty, Dr. Ashok Kapse, who will be presenting on certain issues with COVID-19 disease. We are honored to have you on board, sir. Just a few of good deeds of him. Doctor Ashok Kapse, he is the MD 1974 GRMC Gwalior Senior Consulting Pediatrician. He is Surat ex-National Chairperson IAP Infectious Diseases Chapter awarded. He have won 9 Orations Awards by different academies. He have won Medical Excellence Award 2013 by India Today Group for research in dengue. Would like to mention few of the highlights of this. We are having few highlights like virus from lab or bat, transmission droplet format or airborne, could test be denominator of disease, and many more such exciting topics which are hidden right now. So let's begin with our session. Dr. Ashok Kapse, over to you, doctor.
thank you so much, Raksha, and thanks
Yes.
Mayor for giving me this opportunity. Welcome, friends. I hope you are all healthy and safe and in lockdown, sitting, enjoying your home and family. Friends, I'm going to talk to you about Corona, certain issues about Corona. It was 7 December 2019 when the first time the infection was detected in Wuhan city of China. Was it really December? I mean, WHO, they all say that it is December. That was first time it was erupted in Wuhan. If you look at the, if you look at the first case was detected, diagnosed on 7 December. Now, we know incubation period is around 14 days. So obviously things must have started earlier, maybe mid-November or so. But what the information coming from Wuhan is right from the end of October, there were a lot of cases of respiratory infections, lot of cases of pneumonia, which they thought are probably because of flu. They were treating them with oseltamivir, they failed, and then ultimately they come to conclusion that it is something different, and corona was diagnosed. Now, since its beginning, there were a lot of theories about its evolution, whether it's a sort of a means for bioterrorism or sort of a whether it's naturally evolved from bat. But the commonest theory which is going on is, of course, whether it is bat or from laboratory. You all know how the Western world is hooked up with the idea that it has come out from the Wuhan biolab. Well, WHO doesn't support Western world; they support the China, and there is some scientific reason for it. And what is the scientific reason? Well, at the beginning, uh, this virus, of course, has got a homology with a bat virus, which is known as RATG3, and the homology is of almost 96%. And right at the beginning, when the diagnosis was made, there were two types of this coronavirus was identified. One was L type, and another was S type. The L type was more prevalent in sort of January or so, and it was more virulent also. But S type was commonly isolated from upper respiratory infections, and It was believed to be the ancestral version. Now it is a bit unlikely that a country would release two viruses together, and that is what the stand of WHO, that they believe that it has come from the bat and not from the lab. Now we all know that there are this three portals: nose, then most common, then throat, and the eyes. So covering nose, throat, and eyes also, I again repeat, is very, very important. Now, it's a droplet infection. I don't go into the details about it. Then droplets fall on the surface. You come into contact with the surface. You may get acquired infection. This also, I don't go into the details of it. Whether it's airborne or not, that is something important. Why? Initially, WHO says that it is not airborne infection. China also say it was not airborne infection. But what is exactly airborne infection? These are micro droplets, and these micro droplets remain in air for a couple of hours. In case of corona, it may last for 2 to 3 hours and may spread to the distance of almost 8 to 10 feet. Remain in the air for 2 to 3 hours. So, if suppose a patient of corona coughs out in my consulting room may remain full with virus for some time. If suppose my room is open, it will disappear faster. If it is closed, it will take little longer. Surface survival, well, you all know these things: steel, plastic, copper, cardboard. It has come so often. Viability at different temperatures does matter. Matter of factly, most of the time, these studies are done at 25-degree temperature or AC room temperature. But if the temperature is 35-degree, then viability is only for a few hours. At 25, it is for nearly 14 to 15 hours. At 10-degree temperature, it may last for 3 to 4 days. So colder countries, they suffer more. There are transmission puzzles. I know a family, a girl came from UK, stayed with the family for almost 10-15 days. She came in contact with almost her whole family, which is a big family of 15-20 people. None of them got infected except herself. Then there are situations when you have one person who's infecting so many people, so what you call super spreaders. We all know situations in our country. I don't go into the details of that. What has been observed, that in spite of the best efforts, we are not able to document infection in 55% cases. Where is it coming from? Is it coming from some patients who do not have symptoms? Asymptomatic infection? Well, that's one of the possibility. Now, why is it so different? I mean, one person has got so much infectivity, other does not have infectivity. Some people have got mild infection, some people have got a very severe infection. Well, RDRP gene of this virus, it keeps on mutating. To date, there are almost 250, more than 250 mutations already observed in this particular virus. And this determines the transmissibility and pathogenicity. Something known as viral load. Of course, if there is a severe disease, viral load will be more. Viral shedding is something, virus coming out of nasopharynx. Now, it has been observed with mild disease, viral shedding would be less. With severe disease, viral shedding will be more. Incubation period, it's believed to be 5.2 days. It could be as long as 14 days. And in China, certain children, they documented 24 days. But then I don't believe that 24 days is really an incubation period for this. Now, infectivity period. In a mild case, it is around 14 days. That's why they are kept in the sort of a quarantine for 14 days. In severe cases, those who are in ICU and all that, it could be very, very long, up to 3 to 4 weeks. So that's the difference between infective period from mild to severe. Well, I have just come across a video of some very eminent person. He says that infectivity period is from 10 to 30 minutes. I mean, you need to be exposed to 10 minutes or 30 minutes continuously to the patient, then only you'll get it. Well, in case of a droplet or infection or airborne infection, I don't think this kind of infectivity time is really tenable. It would depend more on the load of virus in the environment. Somebody's cuffs on my face, directly droplets going into my nose and all that. Well, I don't have to be in contact for 10 or 30 minutes. There is a possibility. Those who are asymptomatic patients and who can transmit the infection by, say, normal talking and normal sort of a speech, in that situation, I would may be able to consider this thing, but not in a symptomatic patient who is coughing and sneezing. Now, average number of what you call reproductive number, what is known as RO is 2 to 2.5. Now, with 5 days sort of a incubation period and RO of 2, a COVID patient is going to double every 5 days. And that's the information which you keep on getting from our government, that our doubling time has increased 10 days, 12 days, 13 days. That means probably our RO has gone down. How does it get into the body? Well, there are receptors for this, and those receptors are known as ACE2 receptors. You all know angiotensin converting enzyme. This enzyme is a receptor for this, and obviously, receptors are there on the various part of the body, the lungs, particularly pulmonary cells. Then it is on the heart. Importantly, they are in the blood vessels also. I mean, because they are in the blood vessels, a lot of blood vessel damage occurs. They could be there in the kidney, there could be in testicle also. That's the reason why a case of COVID can become infertile later on. They could be in the brain also. So COVID can have transmission through lungs. Clinical features through lungs. It can
Come
have
inside.
clinical features pertaining to heart, brain, and so many other things. Now, what exactly is this receptor doing? What happens, these receptors have got a anti-inflammatory effect. I don't go into the detail sort of a biochemistry, but they've got an anti-inflammatory effect. Virus, by taking them down, play that sort of a anti-inflammatory effect, and because of viral infection and downplaying of anti-inflammatory, what happens? Immediately there is a lung damage. There's a lot of inflammation in lungs, in blood vessels, and all that, and you get a lot of what you call inflammatory, hyperinflammatory syndrome. Now, looking to pathophysiology, there are three important aspects. One is infection, second is hyperinflation, and third is coagulopathy. I'll just touch them a little bit. Infection, it starts around, say this, then between it starts going up around by 4 day or so, viral load increases. Then in a normal case, I'm talking in a normal mild case, it starts coming down by around 7 days or so. Cytokine liberation is there, it comes, and between 7 to 14 days the virus load disappears. This is a normal thing. But those who are severe, who got a hyperinflammatory thing, cytokine liberation is very high, and day 7 onward, patient starts becoming serious. Now, this cytokine storm can cause clotting defect. It can result into shock because there are a lot of blood vessels involved, lung injury. It can cause cellular death. That's why LDH and all that is very high. Immune paralysis, renal failure. So all these things are because of cytokine storm. Then you have what you call pulmonary intravascular coagulopathy. You get PIC. It is not DIC, it is PIC, pulmonary intravascular coagulopathy. As I said, in blood vessels, there are a lot of sort of receptors. There is an inflammation inside. Inflammation causes thrombosis, thromboembolism. So both lungs simultaneously, diffusely involved. And then later on, this may even cause what you call DIC. Now, if you see the clinical distribution of the cases, what do you find? there are big number of cases, almost 80% they got mild cases. Then there are some cases who got severe, moderate to severe, and then very few they turn critical, maybe just 2 to 3%, severe maybe around 10 to 15%, but majority of them mild. One important aspect is there are good number of cases who go undetected. They are never found out where these cases have come from, and they are detected only on what you call random sampling. Looking at the symptoms, fever, excessive mucus production, dry cough, and shortness of breath. They are what you can say four important aspects of the infection. There could be fatigue, sore throat, muscle pain. Okay, it can occur in good number of patients. But if I have to see the triad, then I would say fever, excessive coughing, and shortness of breath. A shortness of breath when occurs, it's a pointer marker for lower respiratory tract infection, pulmonary infection, and such patient should immediately receive attention. There are 5 stages of infection. One is pre-symptomatic, then there are mild fever, mild stage, then moderate, normal viral infection. By third or fourth day, patients have got a declining this. His fever comes down and patient feels better. In mild cases of COVID, also this happens, but those cases who are deteriorating around 4 day fever intensifies, cough intensifies, and then this patient becomes little breathless. When it's breathless, he's not able to speak properly, he's not able to do his normal routine properly, and he is to be taken to the hospital. Some of them then become critical, that is fifth stage. Now, if you see the timeline of infection, as I said, by around 7 day, patient develops respiratory infection. Those who have to recover, they usually recover between 5 to 7 days. But those who deteriorate by 7 day, the deterioration starts. Then they become breathless. They need to require admission around 7 day. By 8 day or so, there could be dyspnea. There could be acute respiratory distress syndrome going on. Then a patient requires intensive care hospitalization. So all this is the timeline, and so they need intensive care unit and all that. Uh, then they remain in intensive care for almost 2 to 3 weeks. Is COVID other than RTI? Yes, COVID could be other than RTI. And what are this? Well, as we talk of RTI, there could be GI infection, GI tract involvement. The ACE receptors are there in GI tract also, and it can cause fever, it can cause sort of a vomiting, it can cause diarrhea, and such cases may excrete virus for long time in their feces. Still, we do not know the significance of this, whether it is a fecal-oral transmission, we are not sure of it. Then there could be systemic sort of onset, where there could be fever, there could be arthalgia, there could be myalgia, something like dengue kind of a presentation. So we have 3 clinical clusters: RTI, GIT, and systemic. Well, you all know about the risk factors and comorbidities and all that. I need not to go into the details of this. But the one thing, I mean, we all keep on listening. 65 plus, 60 plus. Is it the disease of only senior citizens? Well, look at this chart. This is a Chinese study which says that up to 24 years of age, there is hardly any problem. But after that, you may have 70% cases in ward, 30% cases between 25 to 50 may require ICU care. Well, 30% is not a small number. They may not die, but they may require a sort of thing because they've got a serious infection. Between 50 to 64, same way, around 20-30% cases may require sort of ICU care. Beyond 65, almost 50% cases would require ICU care. But even beyond 65, 50% cases can get well in the ward also. So it's not that if you are 65, that means a death warrant for you. No, That's a wrong information. Now, what's the difference? The difference is flu is classically a what you call catarrhal disease. The rhinorrhea is a conjunctival catarrh. There is a lot of throat secretions, which is not there in COVID. COVID has got a fever, dry cough, dyspnea. Rhinorrhea is there in just 4 to 5% of cases. What about COVID in children? Well, I would say it's a child's play. It's just a child's play. Why I do say that? Well, the disease is milder. Not only that, chances of transmission of infection from child to others is much less. There are two studies, one from France, other from New South Wales, Australia. They have recently come up. Both document a very poor transmissibility from children and much earlier viral clearance. 5 to 7 days, the virus may be clear. In adults, it may take 8 to 10 days. So children, they are less affected. Well, this is again a Chinese study, the largest which has been published till for 4.4% were asymptomatic, 50% were mild, 38.8% were moderate, severe disease almost not observed, death almost not observed. Well, infants are vulnerable. Infants are vulnerable. So up to 1 year, 1.5 year of age, severity may be to the point of 10.6%. Between 11 to 50 years, severe or moderate to severe could be 4.1%. Beyond 60 years, just 3%. Well, why? Why children are blessed? Why corona is not affecting children so badly? There are three possibilities. One is paucity of receptors. Other is colonization with other viruses. Children are usually colonized with many other viruses, and these viruses interfere with the growth of coronavirus. And because of this, what you get is lesser disease, milder disease. But both these things are not well proven. They are documented, anecdotal receptors, these are there, but not classical study. What is most important? It's an effective innate immune response in children. You know, for infection, all infections to begin with are novel. At 1 year of age, child is exposed to pneumococcus for the first time. God has given or evolution has given a classical protection to children. They've got a particular kind of memory B cells which produce natural IgM antibodies. And these natural IgM antibodies effectively curb the novel pathogens. As the one grows up, number of these natural IgM antibodies and this dull kind of MBCs go down. Other kind of MBCs come up which produce IgG type of this. They go into for a long time memory, but their capacity to deal with novel infection goes down because they are not able to produce good amount of natural IgM antibodies. Lot is said about testing. You know, what is this testing? Viral detection by RT-PCR, viral detection by some other method which is non-PCR based, thermal methods and all that, and then there is antibody testing. Just a minute. So we have got antibody testing, a different third type of this. Viral detection by RT-PCR, nasopharyngeal swab, oropharyngeal swab. You can collect it from even what you call sputum, again very high risk, and then stool also. Sometimes it's detected even from the blood, but it's just 5%. Most common is nasopharyngeal swab. Nasopharyngeal swab. So this testing is quite hazardous, particularly to the tester who is doing the test is quite hazardous, and lot of screen is there between the patient and this. And because of this, sometimes you may not hit a classical spot. That's the reason why RT-PCR test may not have a very great sensitivity. It is just 67 to 70%. One single test is just 67 to 70% positive. That means what? There are chances of 30% missing the diagnosis. So you have to repeat the test after some time, and in the after repeat test also you may lose 10% sensitivity or so. So 10% cases may not be detected even in two tests. Specificity is good, but still there are report 2 to 3% cases are sort of a false positive, maybe because of laboratory problems and all that. Well, 2 to 3% is not a very big number, but if you look at the 40 lakhs population infected with this virus world over, this becomes enormous. Well, there are a lot of criticism in India going on about we are not doing enough tests and all that. So I'm not finding the same test for so many other countries also, including US and all that. So yes, tests cannot be adequate. Your Bombay has a population of 250 lakhs. Delhi has a population of 250 lakhs. How you can have so much of testing? It's just not possible to test each and every person. That's the reason why you have to ultimately go for those. Priority would be those who are symptomatic, those who are likely to have disease and suffer from it. Well, this is today morning's data. 22 lakhs 27,000 tests till for 9 a.m. today, and total cases were 95,000. It comes to positivity rate of 4 to 5%. One thing very important, in month of February when we started testing, there were around 15,000 tests, and out of those 15,000 tests, we had around 5%. Today, out of 20 lakh, 2 lakhs also, it is just 5%. So, in fact, number of cases, though are increasing, the transmission in community is not increasing too much. In Western countries, it is to the tune of 15 to 25%. In New York, it is 47%. Well, I had suggested media pool method. The method has evolved from Israel. Germans did it, and at many places they are finding that if you do the test, you can test more cases with single kit. ICMR had taken interest in it, but I do not know if they have used it or not. Antibody testing, well, antibody testing is not meant for diagnosis. This is something like our dengue COVID test, IgM detection, IgG detection. There is a control. Then by 7 days, there are 70% chances of detection. IgM antibodies will be there by 7 days. It is a bit late compared to other infections. 8 days it is 80%, 10 days it is 90%. Now, important thing is when it comes to RT-PCR, by first 7 day, the possibility of detecting is 70%. Or by two tests, around 90%. But by 14 days, it will drop to just 50%. By 21 days, it will drop to just 25-30%. Antigen disappears. In that situation, combining RT-PCR and combining antibody tests can give us a correct diagnosis if you are still thinking of it. Well, government has got its own admission policy, which is in our country is different, USA it is different. I personally feel that asymptomatic infections, they should not be hospitalized. We are putting them in the hospital, putting too much of a patient load in hospitals where people are constantly getting exposed. Then there is a mild, again, that can also be treated at home. I have a couple of my friends who had it in UK or USA and they were treated at home because they had mild infection. Moderate, when the respiratory difficulty arises, they may be put in the ward. If there is a sort of a increasing severity, then you may have to take a decision whether to shift from ward to ICU. Well, this is my guess. There may be some other person may think differently. What about treatment? Well, when it comes to treatment, we have to diagnose, and there are three severity markers which we have to be aware of it. One is lymphocytopenia. The infection kills lymphocytes, and lymphocytes go down, and that's the reason why our sort of a uh, our infection, this lymphocyte, they are killed and infection increases in the body. As I said earlier, there is a lot of involvement of blood vessels, what you call pulmonary PIC, pulmonary uh, this thrombosis and embolism, and marker for them is D dimer. So if you do a D dimer around before 7 days and you find positive, this patient may land into difficulties later on. C troponin is again an important thing because it is also involving the heart, blood vessels, and all that. There is a lot of pressure on the heart, and you may get a sort of, because of PIC, there is a lot of back pressure on the heart, muscles are involved, and that is how C troponin is important. So these things can give you idea about whether patient would become bad later on. Well, I don't go into the details of that, but it's a sort of a viral pneumonia, diffuse viral pneumonia involving peripheries more, both lungs together. Then this, you all know this GGO, ground glass opacification, and all that. Well, we are not going to treat these cases directly. At least I'm not doing it, so I don't go into the details of it. When it comes to drugs, how are we going to treat? We need antivirals. There is hyperinflammation, so we require anti-inflammatory. We also require anticoagulant because there is a significant element of what you call PIC. Well, we do not have drugs. We do not have classical antiviral drugs, but from our knowledge, we know that there are certain drugs which in laboratory has got antiviral effect. In that situation, those drugs are being repurposed to use treat what you call COVID-19. Now, what are these drugs? You know this whole story: chloroquine, HCQS, azithromycin, ivermectin, antivirus like lopinavir, ritonavir combination, favipiravir, remdesivir, ribavirin, oseltamivir, and importantly, convalescent plasma also. All these drugs have got antiviral effect, but not very convincing. There are reports coming up that chloroquine is failing. The reports coming up, ivermectin requires very high dose, not this. Remdesivir, US is hooked on, but other countries are not very happy. Now, this combination of HCQ, CHQ, HCQ, azithro, and zinc, it has helped some countries, and prominent among them is France. There is a study which comes from the France which says that if you combine azithromycin and HCQ, then the virus clearance from even in mild cases is much faster, just 5 days or so. Well, this has become a norm in most of our mild cases all over the country. Well, I believe that convalescent plasma has got a significant role to play. We do not have a sort of a IVIG or containing or what you call high IG levels. So till then we get specific IgG, we have to go for convalescent plasma. Well, it's not something very new. It has been tried in many other things. There is a sort of a meta-analysis of all the severe respiratory infections, SARS, MERS, H5N1, H1N1, and they say that this has got good effect in good number, many of these infections. The importance is it decreases viral load. I do not know why ICMR is averse to this, but I believe that if around 7 days one patient develops difficulty in breathing, if he is given plasma, then his further course, hyperinflation and PIC and all that can be cut down. Early treatment is better result. In SARS and MERS, they realized that when the drug was given as a last resort by 3rd week or 4th week, recovery wasn't very good. But if it is given before 14 days, recovery was much, much better. Could there be viral co-infections? Yes, there are. Matter of factly, corona is known to accompany with flu, picorna, other corona, adenovirus, almost to the tune of 25 to 30%. Now, a patient has got a COVID and rhinoviral infection together, can have rhinorrhea. So those 4%, 5% cases who got rhinorrhea, if we do multiplex PCR, we may find it could be association of some other infection. COVID with diarrhea, well, it could be enteroviral infection with this. So we need to keep our eyes open. And investigate other viruses also, then only we'll come to know whether other viruses are there in this or not. Well, it comes prevention. Well, we have no antiviral drug. So what we do? Social distancing is our main thing. We have to separate, particularly a mildly infected person who is not aware from other person, or a asymptomatic person who is moving in the society. दो गज की दूरी बहुत है जरूरी. You know all these things. Well, masking is very important, and the mask that we, particularly doctors, need to have an 95 mask, a good face shield also, so that our eyes are also not open. A person who is otherwise working in hospital, not coming in close contact with the patient, can have a surgical mask. For a person who is in the street and who is not in close contact with the patient, one can easily have a normal cloth. Then, of course, hand hygiene, you know about this. A rush, respiratory etiquette, you know about it. Chemo protection for doctors who are treating and their family. I personally feel SCQS and azithro, that's important. Of course, ICMR has projected only SCQS. I believe there is no harm in taking once a week azithro also. There may be a lot of people who may think it will cause antibiotic resistance and all that, but in prevailing situation when I am exposed to an infection, I definitely want a better protection. Zinc is very, very important, and why, I'll come to that bit later on. Come immunity boosting. Zinc boosts the immunity. Zinc, vitamin C, vitamin D, then curcumin. But I am hooked on about sunlight and VUR. Ultraviolet rays, if they can come into your house, if they can come in your clinic, they've got a smart sterilizing effect. Now, zinc decreases what you call RDRP sort of a generation. It stops replication of RDRP gene, and because of that, viral is sort of a contained. When, however, zinc needs some drug known as ionophore, which can take it at the cellular level, and HCQ or chloroquine does the same thing. So HCQ plus zinc together, they have got a much better antiviral effect. Zinc, well, these are the things which you can get from chicken, cheese, cashew, all kind of dry fruits, all kind of seeds, milk products, red meat, yogurt, even chocolates also, dark chocolates, cocoa. So zinc you have to increase through diet, or you can have it drug. Well, corona in India, well, we are trying very hard. This is statistics of today morning, 95,000. That's 3 lakhs. Corona in USA, if you compare corona in USA, you find there are 15 lakhs cases. Okay, maybe we are not testing that much, I agree, but US also is not testing that much, and that's 90,000, so we are much better off. Moreover, whenever I listen to ICMR briefing, I feel very happy. 80% of infections are asymptomatic. Well, this is what Mr. Love is telling us every day. 75-80% cases are asymptomatic. What are asymptomatic? If you look at the other countries, Japanese evacuees, they were 31%, Diamond Princess 18%, Italian Village 50%. Compared to all these, number of asymptomatic is much higher in our country. Is it good or bad? Well, I believe it's good for our country. What is asymptomatic? You are infected. You have where nose and throat shows virus. You do not have symptoms. Virus has failed to get into your cellular mechanism, and because it's not proliferating, so infection is subclinical. Well, what better situation you want? You got a lot of patients who have got subclinical infection, and those subclinical infection may spread in subclinical infection to others. Does it happen with other viruses? Yes, it does happen with other viruses also. With H1 also, H1N1 also, good number of cases are asymptomatic. How do we detect them? Well, by a sort of a random sampling, we can detect them. What is the course of events? Well, after 7-8 days, they develop antibodies, the virus is cleared, and these people now are acting as a sort of a people in the society with good immunity, and obviously because they have got a good immunity, they do not spread virus in the society. They are boosting our what you call herd immunity, and maybe by some later time we may have a good herd immunity in the society and virus could be contained. Well, everybody is asking why India are doing well. Everybody expected that we'll have millions of deaths. Did not happen. Why it is so? Well, there are two aspects to the whole. Before that, I would like to say, uh, in cases of asymptomatic, the test has become denominator of infection. It is not a denominator of disease. Now, if suppose the situation is something like that, my throat shows rhinovirus, or my shows pneumococcus, it's colonized, but I'm not having any symptom. Is anybody going to bother about it? No. I would say pneumococcus, okay, fine, it is colonized, there is there. There could be even a staphylococcus colonization, and I may not suffer at all. There could be rhinoviral infection, it could be enteroviral colonization, it could be swine flu colonization, and I may not have any. If I got a subclinical infection and asymptomatic infection, I really don't mind that situation. So in that case, test is just a denominator of infection and not disease. So this number every day, if there are another 5,000 cases, there are another 7,000 cases, mean nothing to me. I believe that those cases who are severe, who are going into ICUs, those who are dying, that number is important. So in reality, our bad cases are nearly 100 to 125, not more than that per day. And look at the population which we have, much bigger than a US population. We are 125 crores. US is just 33 crores. What are the reasons for this? Administrative, very important. Right in the beginning, government took very nice steps, and because of that, and we had few cases, and we went for lockdown. How did lockdown help us? Well, it brought our RO from 3 to 4, which sometimes could be normal, 2.5 to 3. It just brought it to 1, or maybe sometimes less than 1. That's where our doubling time is less. So we are safer. Of course, now once the lockdown is a bit relaxed, number of cases would go up. But as I said, not much bothered about it. I'm more concerned with cases getting into ICU and cases. I'm not bothered about mild cases or even a moderate case. Well, there are biological reasons also. Weather. This is an encapsulated virus, and all encapsulated virus, including swine flu, is vulnerable to heat and humidity. Heat and humidity both are enemy of encapsulated virus. The virus becomes weak. Matter of factly, when I detect this virus in throat, I do not know whether this virus is live virus or just a sort of a I'm detecting just RNA of that virus. I do not know whether it's live or not. So even if suppose I take it from surface and detect it on RT-PCR, it could be just a dead virus. Then maybe it may not be able to survive. It may not be able to proliferate. It's only encapsulated virus which can proliferate. This is a Chinese study which they found out the viral Wuhan had 5 degree, 4 degree temperature in month of January, February. In March, when this went down, their incidence, the temperature was 15 to 20. And they found that most of these cases, in most of the cases, this temperature, colder the temperature, worse is the situation. They studied some nearly 250 of their cities where more than 40 cases occurred, and they found that those cities who had lesser sort of a temperature, they suffered more compared to other. Then impact of temperature is there in other ways also. I just show you this chart. Look at the North America. You got 16 lakh cases. Europe 17 lakh cases. Asia 79,000 cases. So all these things show that in our country, so of course this number has gone up. This slide was made a week before, but compared to North America and Europe, our cases are still much less. Even in US, if you see the hotter south portion, like Texas, New Arizona, and all that, they don't have many cases compared to their northern portion, which has got much more. There is a study which says they've got a different, India has got a different kind of a mutated virus, which has got less accomplished in tying to the S receptor. Well, people dispute it, but there is a possibility that weather is helping us. Well, the theory of malaria says that our P. vivax is also infected with one RNA virus known as matroxy. Our parasites are also infected with viruses. And this particular matroxy RNA1 virus has got a 95% homology in its DNA homology with particular this coronavirus. That's why antibodies to matroxy RNA probably are helping us. I do not know how much the theory is true. BCG is a non-specific immunostimulator. Could be, could not be, but yes, whether it does help. Well, as I talked to you earlier also, senior citizens is most risky age, and this particular situation, what to do, whether this, as a, I am 71 year of age, should I practice? In the beginning, I thought over this situation. I do not have any other severe comorbidity. Yes, I have mild hypertension and I am a senior citizen. Everybody said you should stop the practice, don't go to the clinic. I thought over how many days. Is there a predictability that this virus will disappear within month, 2 months, 6 months, year? If you look at its earlier cousins like SARS, cousins like MERS, they remained for 2 to 3 years. H1N1, right from 2009, it is still there. I may die of H1N1 today also. I could have died 9, 10 years back. I can die today also. Suppose Corona stays with me for 4 years, 5 years. I may die after 5 years also because of Corona. So what I thought, that I take full precaution and keep working. Of course, precautions are very, very important. There is no doubt about it. But there is no predictability. Or I wind up my practice, say goodbye to the practice. I stopped it from today. I will not see the clinical cases anymore for lifetime. If I take that decision, is okay. Otherwise, I take precaution and do a proper continue practicing. What precautions? Well, I think you all know. I just hurriedly go up, see the patient by appointment, don't make a crowd. Take best care of your staff also. If you have got N95 mask, they should also have it. If you got a face shield, they should also have it. If you got a this gloves, they should also have it. Personal protection for them also is very important. The receptionist come to patient comes in direct contact with that in the beginning only. As far as possible, do not touch the patient. I'm not talking of staff. I will have to touch the patient. I'm talking of staff. They have wait. Okay, ask patient to put on the weighing machine. See from the distance temperature. Give thermometer to the patient. Sanitize it after using. Surface sanitization as frequently as possible. For me, of course, mask is important. Shield is important. Gloves are important. Frequent hand washing, sanitization. I avoid all accessories. Those who do not use specs, they can have a sort of a artificial kind of a specs without number, and on the top of that, they can have or a good sort of a uh, eye shield which protect you. As I earlier said, there are chances that most infection occurs through nose, mouth, second mouth, and of course, eyes could also be the portal of entry. So eye protection is also very, very important. I believe PPE is not needed for our OPD purpose. PPE should be reserved for those who are working in the ward, who are working in the COVID ward. Their PPE is necessary. Those who want to wear, I have no objection to it. I do not wear. I find it uncomfortable to use it in my this, and with other precaution, I'm able to take care of myself. Well, should every fever, every respiratory case should be considered COVID until unless prove otherwise? Well, what our data say? A study done in California on the peak of this, published 15 days back, they found that 5% of their respiratory infection coming from community were positive for COVID. Rest were not positive. 95% infections were other than this. As far as other are concerned, I mean, if you take random sampling, if I consider, then in our country, random sampling positivity rate is 1 to 2% only, just 1 to 2%. That means in community infection rate is not very high. So I find no reason that an executive pharyngitis which I diagnose should be subjected to COVID test. A fever case, other 2 days back I had a patient of fever. On second day it came out with a rash, it came out with a classical lymph node post-auricular, and it proved to be a case of what you call rubella. There are another situation when I found that throat has what you call ulcers. There is ulcerative pharyngitis. So I don't think we need to be absolutely crazy about COVID, that unless respiratory infection is there. If you find that patient has got a respiratory distress, intense coughing and all that, in that situation, unless test is done, you may not enter that patient in the ward. Otherwise, a mild case which I normally treat on the day-to-day basis, I would continue making those diagnoses. I'll continue treating this. I need not to be obsessed, crazy, biased. Unless this test is done, I'll not go ahead. What if I am exposed? Yes, this could happen sometimes, no? Well, I lose the heart. Well, I gone. I'm going to die. Well, if I am, say, anywhere between 30 to 50, chances with my good mask, with all kind of precaution, that I would get. Yes, one more thing which I would like to insist. Parents must be masked. Child beyond 5 years should be masked. Small children, maybe you may cover the nose and throat when you are examining. Do not examine throat by spatula and all that, which can create a cough bout. That precaution you must take. Well, if you are between 30 to 25 to 50 and all that, chances of you getting severe disease aren't much. Sorry. So risk of infection is also not very high. Chances of you getting severe infection, unless you have got a comorbidities, hypertension, diabetes, obesity and all that, or a chronic respiratory infection, chronic respiratory problem, are not very high. Well, should you go for testing immediately? No, you wait. Wait, you may go into quarantine, but you need not to test immediately. Test after some time if you become positive. And by 5 to 7 days, most of the cases become positive, sort of a symptomatic. In that case, you can sort of test yourself. Otherwise, you cannot. You need not to do that. Of course, you may remain in home quarantine for 10 to 14 days. Now, I personally believe that if suppose I do not have respiratory symptom, then I did not have home quarantine even for 10 days. If 5 days home quarantine is good enough, and if I develop respiratory infection, the symptoms, then only I'll go for testing and all that. Otherwise, it is not. Of course, I would go for sort of a chemo protection. Well, we are always concerned. What about my family? What about my children? What about my wife? Well, if you got elderly members in the family, keep away from them. Keep totally away. Don't lock them down in a room, or you lock down yourself in a room and don't come out, at least for the first 5 days. You have to take best care of your elderly. Babies under 1 year of age, same thing. You have to take best care. Your wife, she has got as much chance as you have of sort of a infection. That is very little. Chances of serious infection, again, very little. But during this period, you even in the home, I would suggest wear mask. Take full precaution. Older children, maybe around 10 years to say 25 years or so, not bothered really much about them. They are less likely, least likely to get sort of this thing. Well, friends, Corona is a big problem. It's a huge, what you call a monster. But our fear, our confusion, our panic has made it a much bigger sort of a monster. I mean, people are thinking that if they get corona, death warrant. Nothing like that. Absolutely nothing like. Even the medical professionals, there is so much of fear in the mind of people that what to do, how to. Uh, but I feel that all this fear or panic is unfounded. You take best precaution, keep working. We have to learn to live with corona infection for coming year or two. It is not 5%, just 5% till for infection rate in our country, and with 90-95% vulnerable population, your infection is actually probably our trajectory is different than the Western trajectory where it went to peak and then come down. I personally feel that it will be, but it is, I personally that our trajectory is different. We are going to have 5,000, 6,000, 7,000 cases, and for long time they are going to live with us. So we have to learn to live with those cases, and we have to do best in the situation for ourselves also, for our patients also. Well, friends, thank you so much for giving me this hour, listening to me. My best wishes to you for all kind of safe life, and my thanks to Raksha and Mayor company for giving me this excellent opportunity to convey my thoughts to you. Thank you very much.
Yes, doctor. Thank you so much for your valuable inputs. I mean, they had a wonderful time. Doctor, we have few questions right now.
Yes, please.
I'll just read it for you.
Please.
There is a question from Dr. Gaurav Ladha. He states that doctor article suggests that the children have been showing gastrointestinal symptoms rather than respiratory. So how do we detect that?
Well, as I earlier said, that there are three clusters: respiratory, GIT, and systemic. Children can have it, but I mean, I have not come across that kind of a study that in children, respiratory cluster is less, respiratory cluster is maximum, GI cluster could be there. But then, as I earlier said, that whether this virus now I treat a lot of dengue patients. Good number of dengue patients have diarrhea, but is it because of dengue or because of some superimposed infection? I'm not sure of it. Similarly, whether this is there or it's because of COVID only or COVID plus some other virus, I do not know. But of course, we have to keep that possibility in mind for a couple of days. If they do not have a respiratory symptom, then chances of them infecting you directly are very little. You treat it as a viral diarrhea. If they do not respond within say day 2 or 3 and their fever goes up and all that, in that situation you may consider investigating them. Otherwise you just treat it as a viral diarrhea as you treat in other situations.
Yes, okay. There's another question from Dr. Jignesh Mehta. He's saying that if treated early, is there possibility that the children do not catch pneumonia?
I mean, I earlier also said children are less likely to catch pneumonia. Just 10% of children are likely to catch pneumonia. Not even 10%, I would say even less than that. Majority of them, they got a mild to moderate infection. They do not go for severe infection unless they have got comorbidity like a congenital heart disease. They might be having a sort of a some interstitial lung disease or something like cystic fibrosis or some other chronic disease. Then they are likely to have, otherwise not. So you need not to worry too much about pneumonia. And treating early means say giving sort of a combination of azithromycin or SCQS zinc, maybe yes, you may decrease their viremia, but there aren't many such studies which I can bank on them and tell you exactly that if you give treatment, then you will prevent it. But children in general are safer. You need not to worry too much about children.
Yes. Second, other question is from Dr. D. Pawan Kumar Reddy. What parent guidelines to be given if only child is infectious and it is too much of panic?
What parent guidance? What guidance
Yeah,
we
I think if the child is infected, then what guidelines should be given to parents?
well,
And
first and
and because it has created too much of panic.
I know. First thing you tell them that if your child is anywhere between say 5 years to 25 years of age, that is the age when disease is very, very mild. You can show them the statistic. Look, you're nowhere in the world. I mean, child mortality is very, very high. So you need not to worry about that part at all. And if by this, at the same time, you tell them that we are giving you medications. With those medications, there is a possibility that your child's virus clearance will be much faster earlier. So with all that, I think you can cut down their panic and you can definitely assure them that this in children this is much mild.
Yes. Um, Another question from Dr. Ravindra Gehlot. After diagnosing with COVID-19, the children test positive again and again. Maybe that is due to dead lung cell. How do we check that?
Well, I mean, as I earlier also said, that test is a denominator of infection of virus, but not the disease. So a patient who is not symptomatic now, and even just a test is positive, you have to forget about that case. I mean, if you read the literature coming from Korea, literature coming from China, they said that there are good number of patients who had even become test negative and now they are test positive again. Now that test negative could have been a false negative, and there probably the dead virus is there in their sort of a respiratory epithelium for a long time, and now we have to just forget about it. Of course, there are other ways by doing, say, sort of a virus culture and all that, but they are rarely ever done and not needed in clinical medicine. You don't have to go for virus culture and all that. There is one word thing known as uh, cycle threshold, CT, cycle threshold. And cycle threshold says that in how many cycle you find out the virus. A non-proliferating virus is usually seen in very high cycles, more than 40. If virus is detected below 40 cycles, then your virus could be 70, 80, 100, then it is dead virus. It wouldn't be infective. But to be frankly, you don't have to worry too much about it. Don't get carried away with all these things. If your patient has become asymptomatic, he was symptomatic and now is asymptomatic, doing well otherwise, you don't have to worry about this child.
Yes.
Yes.
This Yeah, okay. So there's another question from Dr. Amar Anvekar. Are there any positive effects that if the children have more vitamin D and zinc in the diet from few months to so that it can combat COVID-19?
I agreed with. I think I already discussed this vitamin D. Again, I tell you, you can give vitamin D supplement also. You can take him to the sun for some time. Sun has got ultraviolet rays, and ultraviolet rays has significant sterilizing effect. So both the things you can do. Zinc, as I told you, is very, very important, and all those our old things, golden milk, Hyderabad doodh, and other things, they do contain curcumin, which is a non-specific immune booster, innate immune booster for our respiratory epithelium. So all these things are worth trying. What is wrong in that? I mean, simply because it is coming from Ayurveda and so on, I need not to discard them. They have a scientific basis. Why not to adopt them?
Yes. There's one question from Dr. Shekhar. He's saying what will be dose of azithromycin?
Dose of azithromycin would be for 10 milligram per kg body weight weekly. In case of treatment, 10 milligram per kg body weight daily.
Okay. There's Dr. Sadiq Patel. Many of point are asymptomatic. Many of patients are asymptomatic. How to diagnose in this situation?
I think asymptomatic patients, unless you cannot diagnose them unless you do random sampling, random test sampling, and our government was till far doing lot of random sampling, and with that, what they found is positivity rate from that sampling is 1 to 2%. But 1 to 2% population of Mumbai or 1 to 2% population of Delhi or even for Surat, that's is a huge population. So number of those cases are very huge, and even mild symptoms which they are testing, they find that the test is positive, but the person has nothing. It doesn't have fever. It doesn't have much. So in that situation, I think we need not to worry too much about asymptomatic. I take it as a boon to India that majority of our cases they are
Yes.
confirmed.
Again a question from Dr. Amar Anvekar. Which nutrients should be given to infants to improve their immunity?
Zinc, vitamin D, vitamin C. If you talk in terms of nutrient, then I would say dry fruits, they are good source of zinc. You can give milk and yogurt, they are good source of this. And if you are sort of eating uh, sort of meat or fish and all that, meat and fish are good source of zinc. As for vitamin D is concerned, unfortunately, our vegetarian diet doesn't contain much of vitamin D except fish. In that case, you will have to go for supplement or sun exposure.
Yes. There's one question from Dr. Rakesh Bhargav. What is prophylactic dose? What is prophylactic dose for dihydrochloroquine with high risk senior citizens?
400 milligram weekly. 400
Okay.
milligram.
I think he has a question. What is prophylactic dose for dihydrochloroquine with high risk senior citizens? Like, what does it do?
As I earlier said, dihydroxychloroquine in laboratory has shown to suppress viral growth. And when you combine it with zinc, zinc particularly suppresses the replication of RDRP gene, which is very essential for formation of viral RNA. And this combination together suppresses the viral proliferation in the body, and that is how it acts as a prophylactic drug.
Okay. There's one question from Apurva Rane. What should be the ideal dose of zinc for infants and adults?
For infants and children, it will be 20 milligram. For adults, it will be 50 milligram.
Yes, I think we are at the end of the questions. Okay, so Doctor, any last words? Otherwise, we have reached the end of the session today.
Last word to you, Raksha, and your company for giving me this excellent opportunity. I believe, I trust that lot the panic which is prevailing among the medical professionals, I might have succeeded in dispelling some of those confusions, some of those panicky situations, and they would be more assured in doing their normal work, going to the work, in all over country people have stopped their clinic, they have closed their clinics, sitting at home. I think that's not good for them also, it's not good for other patients. There are a lot of other patients which need you, need me. So I think I take proper precaution, go out, do my normal job. जो होना होगा देखेंगे.
Yes, yes, of course. We'll win in this situation, definitely. Okay, so I'll just resume to the whatever the doctor said, and I'll conclude it. Um I'm very thankful to all the doctors who have attended. I must say, Dr. Ashok Kapse, that many of the doctors have appreciated about the information and all the details we have provided here in the PPT. Thank you so much for that. Also, thank you for all the listeners for attending this webinar. Also, thanking Meyer Vitabiotics for sponsoring, and thank you so much.
Thank you.
Yes, it was my honor to have you on board. It was our honor, our Mayor Vitabiotics honor to have you on board, and we are very happy and
Thank
very
you.
glad that even all the doctors are appreciating and they are very happy with all the knowledge shared.
My thanks to you and your other colleague, the
Yes,
technical person. What is his name? What is
sorry,
his, what is his name? The other person, technical help.
Vaibhav.
Both of you for bearing with me. I mean, I had a lot of problems. I'm not a very sort
Yes,
of a tech-savvy person, but you had a patience with
yes,
me, and I think we could do something good for the people. Thank you.
yes, yes. Definitely, definitely, sir. We'll combat this situation if we have all the doctors like you, and we'll definitely win over.
Yeah,
And also, we are very happy that all the information shared is very useful. I hope and I believe that many of the questions are resolved. And if you can just see that many of them are just replying with their thanks and for sharing the knowledge.
the future
Also,
fight is
yes,
future fight is not with atom bombs and all that. Future fight is between viral genes and human brain. And human brain is most evolved thing in the world. And I believe ultimately human brain will prevail over all the viruses.
yes, 100%. Also, doctors, many of you have asked the question regarding the sharing of the webinar. We'll definitely share with you the link of it. Definitely, our field force, Mayor Field Force, will contact you and give you the link of the whole recording. So please hear it again. They are really willing to hear the same again.
Okay.